made it to December 2025. That is, I think, quite an accomplishment. Welcome to Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. I'm Lisa Salberg, founder and CEO of HCMA and your host for today's podcast. And I am really happy to have back with us again. I don't know what visit number this is. I got to go back and count. Dr. Matt Martinez. Good morning, Matt.
Good morning. Thanks for having me again.
So nice to have you here. And shout out to Lucky in the Philippines, who we are his favorite podcast.
We love Lucky.
We love Lucky. He's laughing right now whenever he watches this. We just made him bust his gut. That's great. Okay. So we've done a little style change here at the Tales from the Heart podcast. And we now are starting with a new segment, which is what is the coolest thing that you saw happen in the HCM space since last we talked? So it's been a couple weeks. So you went to AHA and HCMS. And what is getting Dr. Martinez excited about HCM in 2025?
Well, I think you just said it, right? That collaboration between the AHA, the HCM Society, the HCMS is new. This is the first time we connected with them. So those know that the AHA is a 3 or 4 day event. We now kind of bookend it at the beginning of it. And that allowed us to expand and to offer this to more folks. So we've been sold out the last several years, including the online version. But this year we had a bigger space and no surprise, we sold out again, right? This is such an important topic, over 300 folks in the room and a different feel than other meetings, right? It's got science, we have posters, we have breaking therapy sessions, and then we're intimately integrated in the American Heart Association over the next few days, making sure that the people that we want to hear from are involved in all that, from abstract to late breakers to sessions. So that to me was the coolest thing that I've seen since our last visit. That collaboration is really important in a space that continues to impress, right? Every month or two, we something more novel comes out. Exciting. Absolutely.
So while at the meeting, what did you think was the coolest stuff?
So there were lots of things. I mean, you heard from specifically aficamten about Maple and Forest, right? Those are the big ones for Afi. You heard about the Forest HCM trial, which is like the extension trial, right? Always trees with Afi. Now, of course, they put all the trees together and you get the Forest. So you see now an extension trial with them. Exciting to see what we have seen with MAVA, that we know that it's a sustained benefit, gradients are improved, ejection fractions don't drop to a discernible amount. That's important. And then it showed in that some patients, most patients now, were able to lower the beta blocker. And in some folks, you can actually take the beta blocker away, and they do that safely. Many folks, as you and I have talked about, they still prefer it. It helps with some rate control. It helps with PVCs. It helps control the heart rate, which we know is important in this disease with the relaxation part of this. So I think it shows us the safety signal that we can safely lower the beta blocker. AV nodal blocking agent, still first-line therapy, and we can still lower that beta blocker and then use the CMI as an additive on top of that at lower levels than we've ever used before. I think that was exciting. And we saw that with some abstracts as well from BMS. We saw a Marvel and some other trials showing that similar story. So from a patient standpoint, this is good, right?
From a patient standpoint, I continue to use the phrase, it's a good time to have a bad disease.
Agreed.
We're neutering the disease. We are altering how it functions. We are getting ahead of it rather than chasing symptoms. We're getting ahead of the symptoms now. Yeah. And that is pretty miraculous if you consider where we started with just understanding the physiology of HCM, understanding arrhythmia and HCM. And now let's modify that. And we're able to do that with the myosin inhibitors and some other therapies that are coming down the line. So I was, as you, very impressed with the data that's coming out. It was kind of cool the way that our booth was set up on the exhibit floor. We had our booth here with our heart collection, and then we had Cytokinetics kind of a booth away. Then Pfizer was next with their amyloid product, and then BMS was next with Camzyos. So you look down this row of thick heart diseases, and there was just such a showing of the clinical availability of therapies to treat thick hearts. So I think we are in our golden day of research and development, and I'm excited about it.
Yeah, and we do focus a lot on the big players you just mentioned, but I was impressed also with the patient who had the courage to be the first enrolled in Tenaya. I mean, God bless her. Amazing that she had the fortitude to say, I'm going to be the pioneer here and I'm willing to take the chance. And boy, did she look terrific. Amazing story.
You just literally gave me chills to hear about her. So backstory, Julia did come on the podcast directly from New Orleans. The sound quality was terrible. My ceilings were too high and I didn't have the right audio equipment. So we're going to be bringing her back to talk again. But if you couldn't audibly hear her during that podcast, I asked her why her? I was afraid for her, to be honest. When I heard the first patient was a 27-year-old woman, I wondered, did a 27-year-old woman really, was she ready for this? This big deal.
Yeah.
And then when I heard the story, I was very comforted by her being the right one. Her being the right one. Her mother passed while waiting for a heart transplant in her early 40s. Many family members had died in their late 40s to 50s. And she just didn't know what her future was going to be. And she wanted to have more stability if she could find it.
Yeah.
She wanted to be a woman pioneer in research. And she was willing to give this a try. And she's feeling a lot better right now. Will this last? We do not know. We don't know how much of the gene therapy is needed to treat the heart. There's so much we don't know. But her as a person, her as a human being saying, I will put myself out there for this study for the rest of the community.
Yeah.
Maybe it'll help me, but I'll help others too. She's just an amazing young lady. And when I realized who it was, when she said her name, like, yes, I knew who she was. But they didn't tell me she was from Canada. If they said a 27-year-old from Canada, I would have been like, oh, process of elimination. I know who that is. But as soon as they said it, I'm like, yes, this makes sense. She's 29 now and she's doing great. And she's finishing her first year of nursing school.
Yeah, exciting. I mean, good for her. She's obviously a healer, right? She wants to help the community in any way she can. And we are happy that she was the first and hopefully the first of many, right? If this ends up going the way we want it to.
Exactly.
I want to give one other shout out, right? You and I and others have been on this this quest to improve diagnosis, right? Therapy is important, but one must be diagnosed in order to be treated. And you've heard me say, I fear the untreated and the undiagnosed. Those are the ones that I lose the most sleep over, whether they're exercising or not. And artificial intelligence continues to help us better understand this. We got a long way to go. But in terms of ECG analysis, we saw more of that at the AHA. More people are focusing on that. There are more and more companies saying, how can we improve using AI echo quality? How can we better improve gradients? You're seeing many initiatives through ASE and ACC to try and better improve the quality of imaging so that it's more a vanilla blue ocean kind of experience. So we make the diagnosis because without it, we can't go anywhere. And if we can get it so that AI is not tired in the middle of the night and the AI is consistent and we can compare from place to place, I know the plight of our program is getting the imaging, right? I'm getting wailed on this week to get somebody in. And I keep saying, I just need the imaging. If I can look at the imaging, I can see you tomorrow. But I have to know if we have to move you up, right? I'm happy to see you anytime, but I got to look at the imaging first. So if we can get better at finding it and diagnosing it and following it, I mean, as exciting as the therapy is, I'm excited for that too.
I think we all are talking about AI, right? How can we use it? Where can we use it? Where is it safe? Where is it not? And we're all playing with different types and we're seeing where it can help us. And I have found some really useful ways of integrating AI into HCMA work, but nothing related to clients or patients. It's about grant writing. It's about presentation organizing. It's about email management. And in those areas, it's very helpful. And someday, maybe not too far off in the future, as our patient registry now grows and we get more patients consented in and we're able to look at more variables, we might be able to get to a day where patients can use AI in real time to answer serious questions of what happens to people like me. And we'll need some information and we'll help augment their opportunity to educate themselves, to think about these treatment options and these different drug trials and really think about what it means. Right now, this is all verbal. It's conversations with people, but not too far off in the future with all of the AI capacity, we're going to have something that makes life a little bit easier to navigate, a little bit easier for you to get really good information from curated sources, not the global internet with everybody's hypothesis that doesn't have any scientific backing, but curated to be directed towards the publications that we know and trust, that, not low impact journals, high impact journals, and really good science. So you take the patient experience and all we've learned for 30 years at the HCMA, you put it with the science and you put it with technology. We're going to find ways that make it easier for patients to navigate.
Yeah.
My next great frontier is getting people to cardiology. They're living in primary care.
Yeah.
And the undiagnosed are there right now thinking they have a little murmur and some asthma, and we got to go find them. And that's the next adventure.
Yeah, it's actually interesting because I've talked to others about this, and I feel like I should send a fruit basket to the anesthesiologists or the ER docs who find these T-wave inversions, and they of course go down the coronary ischemia. Like, I'm not going to operate on your knee because your ECG is abnormal, and then they make their way to me as an HCM diagnosis. But that, as you say, that's been rolling around in their chart as a normal ECG for them. But when you and I see it, boy, I mean, it jumps off the page at you. So you're right. Imagine we can have an overwatch for every pre-op ECG that says, this is concerning for hypertrophic cardiomyopathy. Even if you just hear that, you can ignore it, right? You can say, well, I'm not worried about it. I looked at it and I disagree. They read them now as pericarditis and some other things. So if at least we say the phrase, I'm excited that we're going to improve the diagnostic capability. I couldn't agree more. Nurse practitioners, family doctors, urgent cares, pre-op clearance, they're all sitting there waiting to be diagnosed.
They're out there. We've got to go find them. I just had a meeting with a CME company. They're like, we want to put in some proposals for some CMEs. What do you want to do in 26 and 27? I'm like, primary care. Get me in front of primary care. Let's go talk to them. So if you are a primary care doctor and you want to help raise awareness throughout your primary care facility, give us a call. We'll figure out ways to get you engaged because we need to get to primary care. So that's the hot topics. And I was kind of thinking that would be the first 15 minutes. And here we are at 11:15. Don't tell anybody that I'm on schedule because they'll never believe you. Okay. So, Matt, it is the holiday season. And we have a lot of patients out there with HCM and a lot of family members, caregivers, watching them through the holiday season. And like everybody else during the holidays, you eat a little bit more, you drink a little bit more, you party a little bit more, you sleep a little bit less. You're a little stressed out because y'all got your year-end numbers to hit and you got to wrap everything up and you got to start all over again in a couple of weeks at zero again because you're starting on January 1. It's a lot of stress. And then you have that, let's sprinkle in some family members and then let's sprinkle in 2025 politics in America. Things are getting interesting, right? So how do patients manage their physical health, their emotional health through the bumpiness of the holiday season? What sage wisdom can you provide?
Well, I mean, as you stated, the food is everywhere. Everywhere you turn, there's food. And just a little and a little, as we say, you are grazing throughout the day, trying not to hurt anybody's feelings because their banana bread is the best. And that it becomes challenging. So what I tell, we go through this with every patient that comes in anyway. We talk about food and exercise and all those things. But for the next 6 weeks, I change it a little bit. For November and December, the last 2 months of the year, I say to them, don't try and lose any weight. Let's just try and maintain it, right? If we can just not gain a pound, I'm happy with that. And that's going to be that you're going to try and make sure that you use those desserts like they're intended to not overeat on them, but to use them for a dessert as an extra to, food in your day as a reward for a good meal. You've reduced the total calories in your meal. So I still think you're watching what you eat. Higher protein is better. It sticks to your ribs, just like your grandmother used to say. So higher protein, less carbs, a single plate, a more colorful plate. And on my color wheel, gray and beige doesn't count. So if it's fried, that doesn't count. So I want half the plate is colorful, blue, green, purple, fruits, vegetables, all the usual. And the other side can be anything you want. It can be a steak. It can be a slice of chicken, even a piece of pizza. As long as half of the plate is colorful, you're going to be able to sort of maintain your calorie intake. And then exercise. So this is our best appetite suppressant. It's our best way to burn off those extra calories that you may have cheated on. And I've broken this down a little bit differently for those who have not heard this. I usually, the American Heart Association says 150 minutes a week. That's a fair amount to try and get to for those who are not exercising. So that's, 40 to 45 minutes, 3 or 4 days a week, which sounds simple, but it doesn't work that way. So instead, I shoot for 100 minutes. And I say, not only do I want you to get 100 ounces of water, right? That's my hydration talk. But I want you to get 100 minutes of exercise. And the 100 minutes of exercise is 20 minutes, 5 days a week. So if you normally get up at 6:30, get up at 6. Walk around the house, get on your treadmill, walk on the block, whatever you can safely do it. If you give me 20 minutes and you do that 5 days a week, that's going to get me to 100. That's going to really help with appetite suppressant and making sure that you are burning off any extra calories. And then you can always use the weekend to backfill. As you said, you have a board meeting, end up at a holiday party, you can't get up. I need that extra half hour, doc. Great. Saturday morning, give me an hour. Go for a walk. Doesn't have to be burning. Doesn't have to be banging it out. Anything that gets your heart rate above 100, right? Move your body. You got to move your body. And if you can get your heart rate above 100, you are burning calories. So 100 minutes a week at a heart rate of 100 or more, that's an appetite suppressant. It'll make you feel better. It'll give you a little more energy and probably will start you to think more about the calories you take as being, sort of gifts rather than just cramming it all in there. How's that?
That is very good. And this is why I love this podcast so much, because that's great advice. But now from the lived experience side, I always had a hard time exercising in the morning with HCM.
Yeah.
And whether
you're dehydrated, right?
Well, A, you're dehydrated, and B, my heart just felt stiff in the morning. We've seen her and we know she was stiff all the time, but the morning it just took more to get it moving. And the first 4 to 5 minutes of exercise, and I'm not talking like deep exercise, I'm talking just walking on a treadmill, were very difficult for me to get through those first 5 minutes. But when I broke through those 5 minutes, I could go for an hour. So find your best time of day to exercise. And if it's midday, you got to go for a walk during work and it's 20 minutes at lunch, that might be the best time for you, or in the afternoon. So if you can do it in the morning and you can take that 15 minutes and get up early and do it, great. But if it doesn't feel good and you're not doing it because it doesn't feel good, find another time during the day that it might feel better for you when you're hydrated, before you've eaten a large meal. Just get it in there when it makes sense for your life. And it may be trial and error. And it's cold outside right now, so you might be going to the mall to walk. Just leave your wallet at home.
Yeah, it's a really important add-on because I can't do it at night. By the time I get home, I'm cooked. So I can't do it at night. But my MA in our office, she does it every day at noon. Just what you said. So she's like, I can't do it in the morning. I got to get here early. I walk for 30 minutes. It also takes her away from the lunchroom, right? It gives her an opportunity. She's in great shape, but she's able to exercise to keep herself fit. And just what you said, I worry about the ice when you're outside. She makes sure she goes in the safer areas, lots of salt outside our office. But if you can do it in the lunch hour, that is really a good option to add on for sure.
So I'm going to tell everybody now that you're allowed to ask questions today. So if you have any questions, let us know. We just got a comment back that they love the live stream. So we're happy you love the live stream. But it is a group participation project. So you're allowed to ask questions and we'll answer them as best we can. We can't do consult by podcast, but we can answer some generalized questions. Okay.
Yeah,
we definitely want to hear from them. So number 1, hydrate. Number 2, get exercise. Number 3, watch your food consumption. You want to talk a little bit about alcohol?
Yeah. So, when we talk about things that make obstruction worse or symptoms worse, for sure, we think about hot tubs, saunas, dehydration, and alcohol is one of those. So it's a dehydrator. And so if you have more than a couple of glasses of anything, whether it's a shot of Jameson in your coffee or a glass of wine or, eggnog, whatever you do this time of year, a mimosa maybe at New Year's Eve, it's going to make you feel a little worse. Anything more than one is going to make you feel a little worse because it's going to drop the blood pressure. It dilates your blood vessels. And when it does that, usually people feel a little cruddier. Worse in the obstructives than in the non-obstructives, but the non-obstructives still live on hydration. They still live on preload anyway. So alcohol, like we always tell them, I tell, moderation is really critical. I would say 1 or 2 maximum, usually 1, and you can't batch it. Right, you can't have a 6-pack on a Sunday and say, well, that counts for the week. That doesn't count.
No, that doesn't work so well.
Cheating, but you can do a glass a day every day, and that's probably okay for 5 days a week if you had to. But remember, alcohol also has other issues. It interacts with the medicines you're on. It interacts with your ability to sleep. I find as you get older, if you drink later in the day, I can't sleep through the night. I end up waking up. I don't know why. But I wake up at 2 or 3 in the morning and think, oh, and now what do I do? So just be careful. It interacts with all the other stuff you're doing and then can make it harder for you to exercise.
So again, I love this. The doctor's opinion and the lived experience. I found a trick that worked for me. Now, number 1, I couldn't drink at all until I was 40. Which made me very boring in my 20s because alcohol and I did not get along. I'd have a drink and I'd feel like crap. It was related to, my HCM. I didn't really know.
And you were obstructive in those days, correct? We think?
Well, it depends on the age.
Okay.
So I might be admitting to some pre-legal alcohol consumption, but I think the statute of limitations is over now. So I was obstructed until I was 21. And then when I had the endocarditis, the anterior leaflet of my mitral valve stiffened and stopped my obstruction. I don't recommend it as a therapy. So after obstruction, I still didn't feel great drinking alcohol. And then when I was like 40, I tried something. I'm like, oh, that didn't feel awful. So me and Pinot Noir had a little affair. So I liked my Pinot Noir. And then I liked something else for a while. And then there was the apple martini phase. And, they come in phases. But if you had a drink, you'd have to have a bottle of water before, a drink, and a bottle of water after. And if I did that, I didn't feel badly from having the alcohol. And it was an enjoyable experience. But I bookended the drink with a large glass of water, like 8 ounces. And if you're going to have a drink and you really want it, just hydrate first. Don't do it on a really full stomach, but have a little food in your stomach and let your body process it, and don't slam drinks. You're not going to have the result that you want. You'll be on the couch. Yeah. And the next day you'll be bad too.
I was going to say hydration is the cure for the hangover, right? So, but it's hard for me to advocate what you're describing, the preload.
Telling my lived experience. Take the information as you will, throw it away as you might. But that's what I did when I had HCM and I wanted to have a drink. Hydrate, have a drink, hydrate, done.
Fair enough.
Yes. Okay. So we have a question coming in. If you have multiple cardiac issues, how do you know which symptoms go with which disease? This is an excellent question. And I like the layout. HOCM, some blockages, so some coronary artery disease, microvascular spasms, and or arrhythmias or reflux. Yes, it's hard.
Yeah.
There are some symptoms that are very specific. The spasms might be a little bit more specific that they're an actual spasm, but whether you have chest pain due to some coronary artery disease or due to your obstructive HCM, doc, how do we figure out what's what?
That's a great question. So let me do the easy part first. So the reflux part of this, there are some classic ways we think about reflux. It gets worse at night when I lay down. It gets worse after bigger meals. It gets worse with alcohol. It gets worse with heavier meals and often red sauces and things like that. Like peppermint, red sauce can usually make the reflux worse. If patients say to me, I have reflux during the day and I'm not sure what it is, I will tell them to walk. If you walk, and you can walk through it, as we say, it generally, not always, but generally isn't your heart as the culprit, whether it's heart artery disease or obstructive HCM. Obstruction should get worse when you walk. Coronary disease should get worse when you walk. Even vasospasms, they should get worse when you stress the system. So if they don't, I would say it might be reflux, easy therapy. Talk to your primary care doctor about how to do that. Just had this conversation yesterday. They can't get in to see their PCP, so I wrote the drug. Don't tell my nurses because they will not be happy. But I had to write something to try and take care of the reflux. Very classic story. Now, the other stuff, it requires testing. Somebody to tease this out. And what sometimes happens is your cardiologist will be coronary disease focused, heart artery blockage focused. So they will do a nuclear stress test or even a stress echo to look at areas for ischemia where the blood vessels, the blockages are the culprit. So if they do that, you might want to ask, do you think it's obstruction? Because we have patients who have been classically non-obstructive for a long time. They get testing, stress testing, and they say, they can't find anything wrong with me. I don't know what it is. And then I say, you have to do a specific stress echo. And that stress echo is designed to look at the valves. And if they give you contrast, you can't see the valves. So you've got to do it specifically in an area with an expert who can do this. I'm in the room for all of the stress echoes for these, so I can look at the images as they roll off. I think that most people are doing that. I also think sometimes we'll do a TEE where we put you to sleep, pass a probe back behind your throat, and we look at the valve from behind to see if maybe the obstruction is the culprit. So it requires testing, and it's going to require you to speak with your cardiologist about just what you asked me. Which test is going to separate this? These days, I will tell you, I use a lot of coronary CT. So chest, heart CTs to look at the heart arteries itself really helps me sort this out. So it's going to take some testing to do this. And you just got to pick the right ones. And this is when your HCM expert works with your general cardiologist, your clinical cardiologist to come up with the right answer.
I'm hoping that helped our friend MDC, Valentine. I hope that was helpful. I know that I like doing it this way, Matt. You give the clinical and I give it some lived experience. I like this new banter. I had reflux. I still have reflux. It was very different than my symptoms from my HCM, but sometimes they would cross a little bit. But mine all came down to diet. I cannot have anything acidy or spicy.
Yeah, for reflux.
For the reflux. Can't do it at all. And I haven't been able to for like 20 years. Like my esophagus was getting burned because it was really bad. So this has been a long-standing thing. And even after transplant, it's there. So you know that it's there. But after transplant and you have a little reflux and you're like, is this my heart? And you're like, nope, it's reflux. So talk out the symptoms, log them. Log when the symptoms are happening. We have our patient journal that you can write this all down in. It's worse when I walk. It's not worse when I walk. It comes on in the middle of the night. And then you have that conversation with your physician, but you're going in with dates and times and events and very specific. The more specific you can get with your clinician, the more likely they are going to be able to help you tease out where the origin story is coming from. Would that be true, Matt?
Yeah, I think all true. I mean, you got to communicate. I know that the comment that they just put in was, I hate bothering them. And look, we understand that. We don't love a phone call every 10 minutes either. But this is important. If you're having symptoms when you're walking, which is what you're indicating, they all get worse when I exercise, we want to know about it. That's one we want to hear about. We don't need to hear that you're having a colonoscopy and you wonder if you can stop the drugs or not. Most of the time, those are easy and the nurses can handle all that. But these are symptoms that we need to sort out. Is this an important symptom, or is this a don't worry about it, you're just dehydrated? And by the way, a lot of these symptoms are resolved with hydration. The majority of us go through the day dehydrated. So if you can hydrate yourself, HCM patients, like no other patient I deal with, they're exquisitely sensitive to dehydration. The two things happen. Atrial fib, they fall apart, and dehydration, they fall apart. Almost uniformly across the board, they just don't like it. And first thing I tell them is, you got to hydrate first. Let's see how that goes, and then go through all those other things.
So I don't want to bother. So there's some words that I want to take away and add in new ones. I don't like the word bother. I like the word report. You need to report events to your team. And if you call and say, I have something going on, I need to talk to somebody, then you get to the nurse and you're going to report your symptoms. You're going to report what's going on. You're not bothering them and you're not complaining. You're telling them what's happening. Don't feel bad about that.
Agreed.
Women, do not feel bad about it. I know we have been gaslit for a long time that we're just too sensitive and we shouldn't let everything bother us. And it's probably in our heads and it's probably because of our period or it's probably because of menopause. Talk to your cardiologist, explain your symptoms. You are reporting, you are not complaining. You are working with a partner to find a solution. You're not yelling at them because you're symptomatic. You're asking them for guidance, and it's a report.
Yeah, and really, really helpful for the portal. I wasn't a portal fan when it first came out, but the portal's helpful for these quick questions, because if I have to call you every time, that's hard, just finding the time to do that. But sometimes the portal questions are great. Hey, doc, I'm thinking about taking this. What do you think? No problem. That's fine. This is fine. Or I'm symptomatic and I'm going away to Jamaica. What should I do? You got to hydrate. Let's get liquid IV. Let's make sure you bring some electrolytes with you.
Wait. Explain to people what liquid IV is, because I think they're going to get an IV on vacation.
No IV. So liquid IV. So liquid IV, these are electrolyte supplements. That's one of them. We're not sponsored by them that I know about, but maybe we ought to be as often as I quote them. So these are powders or standalone drinks that you would add to that. So we push water, which we should, but any activity over 45 minutes, we should be converting or adding on electrolytes. So there are different versions of this. My wife likes Element, LMNT. It's like a little packet that she adds to it. There's actually a hot chocolate version of it that to me tastes like salty hot chocolate. No thanks, but she really likes it. You can add Noon, N-U-U-N. These are tablets. They look like Alka-Seltzer, and you bust them up and put them inside your water. And what they do is that they make the water basically a flavored electrolyte. Gatorade, Propel, vitamin water, those sorts of things all fall in the same category, but you can carry them with you as a dry rather than having to carry that big bottle like Gatorade. And the
I take them when I travel out of country, because I'll only drink bottled water, and I might get the one that has a little caffeine in it too. But I have like the sports supplements that I travel with just to stay hydrated on the plane all the time. Yeah.
So those are nice add-ons for folks. And the way somebody said, how does hydration help the symptoms?
Yeah, let's flip this question and then we'll go back to his for a second, but because it's on hydration. How does it help?
So it's really important to think about HCM as the heart is stiffer, and the cavity of the heart is this part in the middle here where there's blood, right? So that blood is there, but because your heart is thicker, it's smaller. So when it beats, there's less blood with every single contraction. So what we say is you got to fill up the tank, right? So you fill it up so there's more blood inside the heart. If you're obstructive, it makes the obstruction go down. So the valve no longer gets in the way as early, so the symptoms can be improved. If you're not obstructive, you just increase the amount of blood that you're squeezing out with every single beat. So there's a phenomenon in cardiac conditions. The technical term for this is preload. So we think afterload is high blood pressure. Usually, people are going to argue with me about this, but generally we think about afterload as being a higher blood pressure. It's a higher resistance to what the heart is squeezing against. You can have a normal blood pressure and high afterload. So if the cardiologists are listening, don't yell at me. I understand that concept. But elevated afterload means there's a higher pressure for the heart is squeezing against. Preload is the filling up of the heart muscle. So that's hydration, water, electrolytes. It's how filled the heart muscle is itself. And because the cavity is smaller, because it's thicker, you're going to fill it up and make it squeeze more efficiently. That's the best way to understand this, that you're making the heart fuller so that it's able to fill and then squeeze out more blood with every contraction. There's a tipping point, though, in some versions of heart failure. If the heart becomes weakened and you start to get into the other side of this, which is a little bit unusual, but it can happen, that we then start to limit your hydration. So that's a conversation, again, as Lisa says, with your cardiologist. Where am I on this spectrum? Because we tell heart failure patients, pre-transplant patients, people with weakened heart muscles, limit the amount of water because otherwise you fill up like the Michelin tire man.
And it depends on the way your heart is failing. I needed hydration up until the very, very end. Yeah. I was not hydration limited, but most people going to transplant are. So it gets tricky out there. And you also want to think a little bit about sodium and how it plays in here. If you deplete yourself of all sodium and you go on a no sodium diet, that's not good for us. We don't want to be on a high sodium diet. You want to be on the low end of normal for, I think the American average is ridiculously high and we should be lower than that, but don't go high salt, don't go no salt. Keep some sodium in your diet.
So that's what those electrolyte packets are, right? They're generally there's a high sodium content, especially in Element, that I have to cut it. It's too salty even for me. But that's a conversation with your doctor. Exactly what you just said. Where am I on the spectrum? How much can I take? Someone's saying there's a fine balance here. And that will be a little trial and error for you, right? You're going to have to figure out where you live in this. Maybe for you, it's 2 bottles of regular water and a bottle of electrolytes, and that'll be enough for you for the day. But you've got to sort that out. And then, of course, couple that for the older folks who are listening, saying, you're going to hydrate me, and then I'm going to spend the rest of the day looking for a bathroom. And that's true. But that's the balance we have to go with. I have the same issue, right? I drink a lot of caffeine. I drink a lot of water. So I have to make sure that we know where the bathroom is for sure, because
at all times,
because it gets busy as the day goes on, for sure.
And for those on diuretics, we know how to time that, and you do not take your diuretic before you're going to sit in traffic on Route 80 for an hour and a half. It will not go well for you. Just will not.
I hope that helps with the hydration discussion, and that's a great question. I think often overlooked.
So I think that was a good discussion. We're getting some comments back that they're feeling that they understand it better. So back to Anthony's question. So you're welcome. And congratulations on your weight loss through diet and exercise. Fantastic. 60 pounds off. You got on Camzyos, which helped you exercise. You're exercising for an hour, 5 days a week on a stationary bike, doing 18 miles. Could he be doing too much? Could he be damaging this? Should his wife be concerned, Dr. Martinez?
Good question. So that's a really good question. So I love what you're doing. The exercise is important. For men, typically 150 minutes is actually the maximum you're going to gain benefit from. Women can actually gain benefit up to 300. I'll let you decide why that is the case. My wife has a very firm opinion on why women are better, but that's a different discussion.
Maybe we need her on a future podcast.
That's important to know. But we don't think you're doing damage to your heart muscle. So we've never shown that exercise damages the heart muscle in HCM per se. However, there's some caveats to that. One, you got to make sure you talk to your cardiologist about an exercise prescription, what's safe for you. It isn't a one size fits all. We actually wrote about this. There's a free exercise prescription online. You can get through the ACC. It's free to download. Your cardiologist can give it to you and talk to you about what mild exercise looks like, what moderate looks like, and what's vigorous exercise. Short story, mild exercise, you can have a full conversation. You're with very limited ability to still talk. Moderate, you're having some trouble having a conversation, maybe a little bit sweaty, and you're definitely feeling breathless. Vigorous exercise, generally don't talk. Unless you're an elite level athlete, people who are running a 6 and 7 minute mile can't talk. So if you're unable to talk, you're vigorous. So you want to do that maybe one day a week at most. You don't need to be banging it out that level every single day. But there are some exceptions to that. So talk to your doctor about it, but you're not harming yourself. The second is that when you exercise, you should be exercising in a safe place. That should be near somebody who has access to it, in a gym with somebody there, maybe when your wife is home. Like it or not, you're in a different category than everybody else. Your risk is still higher than others. It's not zero. And I worry that the message about exercise in HCM is now pendulum swinging the other side, where we say, it's nothing. That's not what we're saying. What we're saying is that it's a wide spectrum of disease, and some people have very low risk when they exercise. Some people have higher risk when they exercise, and you need to figure out where you are on that spectrum, and your expert will help sort through what that exercise prescription looks like. But all the other things still apply, whether you're low risk or high risk. It's too unpredictable. Still got to exercise with somebody, still got to have a safety plan, still got to know what symptoms are worrisome to both your wife and any colleague that's with you. If you have breathlessness that's out of proportion, if you're having chest pressure, if your symptoms have changed from the prior, don't ignore them. This is your chance to reach out. But exercising with a buddy or in a safe space is, I guess I can't overstate that. I think that's a critical piece to this. Try not to work out by yourself alone in the backwoods of New Jersey or anywhere else.
So I pulled up a video that was sent to me by a client where he had a ventricular fibrillation episode on a treadmill in a gym. Amazing. That had cameras on. And I'm going to see if I'll try to get this online where you can actually see him doing this. I have his consent for this, obviously. But because people were there and he did have an episode, they responded very quickly. Now he gets up a minute later, like, what the hell happened to me? Because it's not his first rodeo and he knows what an ICD shock is. But it's an unsettling event. It's important. It was reported to his physician. But it's very dramatic and you don't have a lot of time sometimes. If you don't feel well, you're going to go down if it's, arrhythmia based, which this was. So you don't want to go down when there's nobody there. And you really want to think about the exercises that you're doing. If you're going biking outdoors, great, but have an emergency plan and make sure somebody's with you if you do need to stop. So I highly recommend the minute you think you need to stop. Don't wait to see if it progresses. Just give yourself a second and then you can go back to exercise. As we know, a lot of times these things just resolve on their own and we get back to normal and then we can slowly start doing exercise again. But don't see how far you can push it. Stop when you feel anything that doesn't feel quite right. You'll learn your body over time the more you exercise. Going back to this gentleman who's doing 18 miles, is that a week?
On a bike.
A day. It's 18 miles a day.
Yeah.
Is it more important to know the distance or the speed?
So the distance makes me less nervous than the speed. So the speed is more concerning to me just for a couple of reasons. One, the heart doesn't have as much time to fill. So the hydration becomes really, really critical. And those who are exercising this long need to spend some time understanding hydration. So the distance matters less to me, although, again, anything over an hour, you're going to need to hydrate and electrolytes and all that sort of stuff. But if you're sprinting portions of this, or you're doing HIIT training where it's fast and then slow and then fast and then slow, I want to know more about that. There are some subtleties in this question that need to be sorted out by an expert in the field. And it sounds like you're being seen by somebody in a COE, and that's important. So having a conversation with somebody who's an expert about what is safe and what is not safe, they should be drilling down for you, and I'm sure they are. But there's some subtleties to this conversation about how quickly you're going. Are you doing ramp? Is this a stroll, or are we banging it out over those 60 minutes? I need to know a little more about that. The 18 miles a day on a bike is not as much as it's 18 miles on a run would be a whole different animal. You can coast some of the stationary bike stuff.
Okay. Sherry's question. She had a myectomy.
Yeah.
It's done now. She was Ironman marathoner. God bless you. Could never do it. Trying to figure out why her symptoms didn't go away with surgery. I will open this by saying not all of the symptoms from HCM come from obstruction. Some of them are due to the fact that the heart muscle is stiff and non-compliant. And I would encourage you to have a really good understanding of your anatomy, and you may need a stress echo, an MRI, and potentially some other testing to evaluate why your heart isn't as compliant as you want it to be.
Yeah.
And figuring out how to optimize what you do have. Would you do an Ironman marathon again? Maybe not. A 5K or a 10K and some other activities? Maybe. Dr. Martinez, what should she do?
Yeah, just a comment about the Ironman. The Ironman is a grueling event, no matter who you are. I mean, it's a long day, full day of exercise that would be a outlier for most of us. And I'm not saying you can't do it. I'm just saying that that's a complicated conversation that you may need to work up to with your Center of Excellence expert. And then I can't understate or overemphasize that by removing the obstruction, you take away one portion of how you get symptomatic in HCM. But non-obstructive HCM patients often have similar symptoms. They are breathless, they can't exercise, the heart muscle doesn't squeeze as efficiently, and it's stiffer, right? It's stiffer than it's supposed to be. So it doesn't handle higher heart rates the way you need to when you're an elite level athlete. So it's probably that we converted you from a lot of symptoms with obstruction to lesser symptoms with non-obstruction. And it may be difficult to get rid of those symptoms altogether. So I agree with what Lisa just said. A, make sure that you don't have obstruction that's residual, that maybe unrecognized. It can come back. The heart muscle doesn't grow back, but the angles do change. The leaflets can change. It can happen unpredictably, even in a great center with a tremendous, post-surgical outcome. I've seen them where I'm like, I don't know why you're obstructive again, but you are. And so you make sure that you manage that. And then there is some limited data from Ben Levine talking about HIIT training, where you do higher exercise, lower exercise. So you do, sometimes they call it like the 4x4, where you run faster for a short period, then walk short bursts of energy. And that has been shown to increase peak VO2. So there are ways you can increase your exercise tolerance by having a very regimented way to sort through this in terms of improving your peak VO2 and your exercise tolerance. So you can do it. Odds are you have non-obstructive stiff ventricle that we need to address. Maybe some of the new medicines, SGLT2s, maybe in the future, the CMIs may have some benefit for this to try and offload some of that pressure, but that requires a complete evaluation. And then remember that coronary disease, heart artery blockages still are important in this disease. They chase you down, right? We've treated the HCM, but high blood pressure, high cholesterol, your genetics, they can all lead to coronary artery disease. And that's where I go away from stress testing and I do a CT angiogram. So I do a lot of the CT angiograms in this group. It's been shown to be unbiased, where we know that stress testing in women is not as helpful as in men. Most of the data is based on men, so we have to be mindful that women are different and that they behave differently. Their symptoms are different. Honestly, they tolerate symptoms differently than men do. They off because they're busy and their life's in the way and they blow things off. And men do for a different reason, but I think women are just saying, I don't have any time for this. And
I'm going to pick on Matt just a little bit for a minute, and it's not his fault. It's a common saying. It's a really interesting social comment that we refer to women being different than men rather than men being different than women when we're talking about signs and symptoms. But it's so true. We think because, we're people, the experience of symptoms and disease progression and everything is going to be the same and the tests are going to be the same. But we know that they're not. Yeah. We've known it for a long time, but we haven't done the work to show where the separations are really well, specifically in HCM. Like, should women be getting CT angiograms more often? We probably aren't doing that many of them right now. Maybe you are in your program, but others, it's not a big thing. Yeah. Maybe we should be doing more. And we do need to talk more about gender equity and the health of women entirely. We typically think of women's health as the bikini areas, but the health of women is so much more. And there are so many differences. I will step off my feminist soapbox right now.
Yeah, no. So this is important. And the reason we often say that women are different is because most of the data early on was on men, right? So we're comparing it to that. But the truth is that the way people present, men or women, can vary considerably. And in HCM, stress testing is particularly challenging. Nuclear stress tests have a lot of false positives. Stress echoes, the more of an athlete you are, the faster the heart rate drops back down to normal. And then the sensitivity, the ability to detect disease with a stress echo with a lower heart rate is not as good. Where CTs have been shown to be gender kind of neutral. It looks at the pipes and tells you, are they blocked or are they not blocked? And if that helps me say to a patient, your coronars are open, the symptoms you're having are related to that stiffer heart muscle, diastolic dysfunction, and don't forget that other things creep in your life. Exercise-induced high blood pressure. I just recently treated somebody who was symptomatic when they exercised. I ran them. We did the treadmill, and their blood pressure went through the roof early on. So by treating that blood pressure, even though it wasn't super high at rest, we were able to blunt that response, and she feels terrific, because we were thinking about other reasons why her stiffer heart can't handle a blood pressure of 190, and it turned out that was the case. So there's no good ways to improve the relaxation of a stiff heart muscle as of yet. There's a lot of ongoing work for this that maybe the CMIs, maybe it'll be some other version. Perhaps this is what the Sonata trial is going to show us, that I've had good experience with this. And what I do is I usually will draw up an NT-proBNP to give me an idea if the patient is having an elevated pressure inside the heart. It's a blood test that looks for elevated pressure, and we have most of the data on heart failure patients, which are traditionally weakened heart muscle, where the muscle function is lower, but we can use it in HCM patients, and most of us are using it more now in the last 5 years than we did in the previous 5 before that. So there's some value in that. And then, as I mentioned, the HIIT training can help with stiffness, offloading the blood pressure, making sure the blood pressure is controlled, using SGLT2s. Those are the ways you can impact the stiffness, so to speak.
Okay, we're rounding out the day. If you have any last minute questions, post them now. We're live at 11:54 a.m. on December 5th. If you're watching this at another time, you can email us at support@4hcm.org with any of your questions, or join us in a discussion group where we can address those questions as well. So Margaret has a question, and you're welcome. We're happy to be able to do this for you. And yes, women and men are different. Diagnosed 2 years ago, even though the heart murmur has been found years ago. Possible bouts of asthma, a few months before it resolved. on its own 6 years ago after many lung tests. My guess would be you were diagnosable many years ago. And I'm sorry it took you so long to get to your proper diagnosis, but it looks like you are on the right path.
Yeah.
And you started Camzyos journey later this month. You will be starting it. So let's look and see and wait and see how your numbers improve and see how your symptoms change. We have seen some pretty impressive results from myosin inhibitors, and we hope that you are one of those who benefit.
So she gives a good story of cardiac asthma, right? Where it's the heart that led to the asthma diagnosis. And I've heard you say this, and I've stolen it from you, where you say, "Show me the PFTs. I want to see the pulmonary function test before." I don't believe you, but I don't believe you, because most of the reason people are breathless isn't asthma. I want to hear about wheezing. I want to hear about cold symptoms. When you exercise in cold weather, it might be worse. And then show me the pulmonary function test. Show me the test where you breathed into a tube and we did a reversible agent and showed that. If not, it might be HCM until proven otherwise. So you're going to do a correct stress echo, and it looks like we found this in you eventually, which is terrific. I'm glad they found it. I'm glad that we've got a medical therapy for you. But we want to try and catch folks earlier than this. And we keep talking about stiffness. One of the things that a lot of us talk about is, are we leaving obstruction untreated for too long? And that's what's worsening the stiffness. And boy, there's some pretty compelling reasons to think that that might be the case, and that you're seeing surgeons even talk about operating earlier and maybe some medicines, that we need more work to be done, but leaving obstruction may not be as safe as we think it is. And we got to do some homework on this in the next years to come.
We absolutely do. There's a lot of good trials that are opening. Some of them are a slow roll to open. Some of them are open right now. So Sonata is open. Obstructed, non-obstructed. If you're having symptoms and you're not currently on an SGLT2 and you are interested in the trial, contact the office. We can hook you up with a site location. The Embryo trial on Ninerfaxstat. Did I do that one right? I think I did that one right.
I usually have to practice it several times before I say it out loud.
I did it once in my head and it came out right. I like brand names because they're a lot easier to pronounce, but the Embryo drug, I'm not going to get it right twice, is open for clinical trial in some areas and will open within the first and second quarter of next year. If you've taken our survey and you've indicated you're interested in one of those sites, we'll contact you when it opens. And if you're interested in one of the active sites, we can get you into that. Right now, most people don't like to start a clinical trial like right going into the holidays. So we're going to kind of put the pedal to the metal in January on a lot of these trials and letting everybody know where they are so they can start evaluating which clinical trial might be right for them. So we have those coming up. We have some additional trials that'll probably start mid 2026 to end of 2026 that will be into some new therapeutic areas that we're going to start to have to talk about. We've not been there before with this new concept called RNA silencing. And we just got talking about genetic therapies and AAV9 versus CRISPR, and we're just getting to understanding there. Now we're going beneath the DNA to the RNA to turn off part of the signal so the protein doesn't get sent upstream. And there may be some benefit to some of these modalities. So we're going to all learn together over the next year about these mechanisms. And we're going to learn about these companies and trials. There's a lot coming in 26. I'm trying to not be as crazy busy as I was in 25.
Good luck.
Anybody who is a really good scheduler, planner kind of person that wants to volunteer some time to help us figure out how to find more hours in the day, please come forward, because I'm trying to figure out how to get everything done. We did 2 site visits this fall for new centers in the Northeast. We have a few more coming. We did some in the Midwest and some in the South that are going to be announced in the next couple of weeks. We'll be launching 2 programs in February. Heart Month is coming in February. HCM Awareness Day, last Wednesday of February every year, February 25th this year. If your clinic, if your work team, if your home wants to do an HCM awareness event. We're going to have materials to send out to all of you so you can run events on that day and really draw attention to what we're all doing here together as a community. We're kind of unique, people. There is no other structure like what we've done here. We helped develop the care model. We have great relationships with fantastic clinicians and researchers like Dr. Martinez and his colleagues. We're working directly with patients every day. And yesterday I was down in Newark, New Jersey, talking to 40 ministers, imams, and rabbis about how to bring family heart health history messaging into the worship space. So we are working on so many different angles simultaneously. And we're going to have our 30th anniversary in February.
Wow.
30 years.
Wow.
We've been doing this.
Started when you were a teenager or younger.
So reality is I was 27.
Whew.
And I thought, I could fix this. The audacity of youth. But we had an idea. I had a dream. And it all came back to one thing. My sister shouldn't have been cared for the way that she was. And nobody else's sister should have to go through what my sister went through. And somehow that turned into the rest of my life. And it's been a wild ride, and it has been a really eventful 2025. So as our last podcast of 2025, Matt, I look forward to our future podcasts and what other advances will come and how else we can help give explanation to patients on real life issues in real language, in casual conversation, to help them understand their disease, to take some power back, and to be their happiest self and their healthiest self that they can be. So a big thank you to our sponsors who will be dropped in at the end because the list is long now. Thank you. And in 2026, you're going to hear some new names coming in, and we're going to introduce you to these companies and these companies to you as a community. Coming up also in 2026, very important event on April 23rd, we will be holding an externally led patient-focused drug development meeting with the FDA, and that will be based on genetic and RNA-based therapies. So we're going to talk to the FDA about what we are dealing with and what we want out of therapies. You're going to be getting a very important survey in the first quarter of 2026 that we need you all to fill out. We need to hear exactly what you're feeling so we can document it appropriately in what comes after the PFDD, which is something called a Voice of the Patient report. That Voice of the Patient report gets filed with the FDA, and people who are interested in our space, creating therapies, they look to those reports. And there's going to be a company that we're going to tell you about next year that actually came about because of our first PFDD. And we told them one of the unmet needs was atrial fibrillation in HCM.
Yeah.
And there might be a new therapy coming down the pike just for HCM AFib, not AFib, HCM AFib. Crazy. So your input matters. You are an integral part of this community, every single viewer, everybody out there. I don't care if you work for industry, you're a clinician, you work in an HCM center, you've stumbled upon us and you're like, this is different. Yeah, we're a little different. But we're here building an ecosystem together. And it's been an amazing journey for 30 years. And I'm actually looking back going, all right, maybe I did a thing. Maybe we've succeeded in some ways, but really we've succeeded in a lot. And I've got a lot of gratitude for everybody that's helped us get here. And now to all the patients that you treat this holiday season, know that you're part of their thoughts this holiday season of things that they're grateful for.
Well, I'm grateful for their engagement. This was a terrific podcast because of the patient engagement. I love when the banter back and forth between you and I is only aided by their conversation. Reminds me, careful with the jargon, make sure that you explain some of these things because we're doing it all day long. You know, Marty Marin and I talk about how it's Groundhog Day, right? We saw 12 patients again for the HCM. So sometimes we forget that when I talk about liquid IV, I know what that means 1,000 times, but a new person may not. So this has really been a tremendous session. Thanks for the patient engagement, and I'll see you all next year.
See you all next year, and I wish you all a happy holiday. If I don't get to see you before then, may you Make memories. May you remember great memories, and may you enjoy your time. Matt, thank you so much. Ross, thanks for dropping the links in the back end, and thank you for all of your participation today. Have a great one.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.